Namaskar to all the viewers of this Foxy Presidential Initiative Gyan Pravah podcast series. And today is episode 204. And I'm Dr. Archana Kumari, your host for podcast on 20th of every month. I feel so honored today to welcome our beloved Foxy President, respected Dr. Sunita Tandulwadkar, Madam, and I'm also honored to welcome the guest faculty for today, another great Foxian, Professor Dr. Aswath Kumar, who has been the past chair of quiz committee, Foxy. That is how I connect with him. And also because both of us are postgraduate teacher also. So we have selected this very interesting topic for today's discussion, that is postgraduate training, past, present, and future. But before we start the engaging conversation, let me just take a moment to congratulate Madam for this unique initiative of podcast series, which is live at 8 p.m. every day. And today is a proud moment of celebrating 204 episode. So congratulations to Madam, to all the Foxians also. And sir, as we were discussing earlier, this podcast is actually a flow of knowledge, Gyan Pravah, where the madam has given opportunity to 30 committee chairperson to be in conversation with different guest faculty, not only from the field of medical science. We are discussing spirituality, we are discussing finance, we are discussing psychology, and so many things. So truly, it is a continuous flow of knowledge. So, as it is customary to introduce Sunita, Madam, President Foxy, but I know for Aswath and for all the Foxians, he doesn't need any introduction. But, sir, I would just like to mention about Madam's a few key initiative for this year, because I know Foxy will remember year 2025 for unique projects of her. Know Your Number, Do Tike Zindagi Ke, then this Sampurna Swasth Janm Abhiyan. I remember at AICOG, we inaugurated the Sampurna stall and I conducted quiz on preconception care. Although Madam was so busy, she could not participate. I have that video. I'm going to present it during quiz committee chair report. And of course, I also want to mention about Eagle Project. Every aspiring gynecologist should learn, can learn endoscopy, and recently it completed 100 number. And I'm also looking forward to this project to organize it in my college for the postgraduate. I wanted to highlight this project because today we are discussing about postgraduate training. So Eagle Project has to happen in my college also. So with this note, I welcome you, Madam, for your pearls of wisdom.
Thank you. Thank you, Archana. Thank you so much. Ashwath, welcome on a Foxy platform. These podcasts are for 365 people and it's very chosen. I think in a Foxy leadership, hardly we have taken 15 up till now. So feel fortunate that Archana feels that you are one of the most important person who should be faculty on this podcast. So congratulations for that. And Ashwath, you deserve that position. It's every day I meet from even non-gynac academic like Dr. Trehan, we are going to meet 2 days down the line with Poonam Goyal's meeting, and so many academicians excelled in their field, not necessarily gynae, but as she said, the global leaders from every backgrounds, political, philosophical, philanthropic. It's so beautiful. Actually, I designed it only for the chairperson. But believe me, Ashwath, every day I join at 8 a.m. just to say hello and just to show the respect to the faculty that Foxy welcomes you, Foxy respects you. I am enriched meeting so many faculty. Believe me, I don't know. This Pravah series at the end will collect such a valuable knowledge flow of 365 hours program. It's going to be huge. It's going to be huge. Let's see what
Absolutely.
we can do with it. But today, I think the two teachers talking about past, present, and future will be one of the best discussion And I request Archana, Ashwat do have many postgraduate links. So once this podcast is over, please give him the link and he will circulate to the student because this is very valuable to them. And you also can circulate to all Foxians and other medical colleges. Thank you so much, Ashwat, for taking
Thank you,
out
madam.
time and coming on Foxy platform. We welcome you and we feel honored. Thank you.
Thank
Thank you,
Archana,
madam.
if
Yeah.
you don't mind, our Mukta project initiative is going on right now.
Yes.
So I will join the link. I know
Yeah.
Ashwat very well. I just wanted
Yeah.
to give him great
Thank you
regard.
so much, ma'am, for joining
Thank
and encouraging. Thank you.
thank you.
Okay. So it is now my time to introduce and my privilege to introduce the guest faculty for today. Dr. Aswath is a renowned gynecologist, laparoscopic surgeon, and an academician par excellence. He holds advanced international training from France, Austria, and has completed his fellowship in gynec oncology from GCRI. Currently, he serves as a professor in Department of Gynecology, of course, at Jubilee Mission Medical College, Thrissur, Kerala. And of course, his leadership journey in Foxy includes serving as president of Kerala Federation of Obs and Gynae in 2023, vice president of Foxy in 2019, vice president of Kerala Federation in 2017, and chairperson of Foxy Quiz Committee from 2012 to 2015. And he continues to contribute as governing council member in ICOG and managing committee member of IAH. And your academic contributions are equally impressive. You have authored so many books, published widely, delivered 200 faculty presentation, 10 orations, and your excellence has been recognized by several national awards, including the Pride of Foxy Award in 2019. We are truly honored to welcome you on the podcast. Welcome, sir.
thank you,
And
madam.
now we begin our conversation about the very pertinent topic which we discussed and decided to discuss, that is postgraduate training. We will be talking mainly with respect to OBGY training, past, present, and future. As we know, NMC is coming with competency-based curriculum, not only for UG but also for PG. So this conversation, I would like to start with your experience, sir. Could you briefly take us back in time? How was postgraduate training in Obs and Gynae in your era? Or I would say in our era,
Before
maybe
starting
20,
the
30 years
question, I
ago.
have to thank Foxy and especially Sunita madam and Apsana madam for inviting me to such a prestigious podcast actually. So I am so honored to be sitting here with Archana madam and Sunita madam. So thank you so much. Without wasting time, we will go into the matter. As Madam has asked, I did my post graduation from BJ Medical College, Ahmedabad, in the year 1999 to 2002. I still remember the days of my postgraduate. I'll just small, I will tell you.
Yes, sir.
The day, the first year, it was so hectic, actually, so hectic. First year was so hectic. And that means we had long hours of work, but lot of clinical material was there. About 30, 25 to 30 deliveries per day was in the labor room. And we got lot of exposure, but in the opposite was that I never used to get time to go to my room many days actually. We had to spend lot of time in the wards actually. But the advantage is that the focus was at that time mostly on the clinical experience. We actually speaking, not that our teachers were very good actually. Teachers like I had teachers like Harish Doshi, Parul Kottawala, and all good teachers which are
Oh,
named
Parul
in
Kottawala
Foxy
sir
as
was your
well as
teacher. Nice to know that.
and
I
teachers were
absolutely
there.
respect him.
Then
Yeah.
also, madam, the thing is that the regular taking class, that concept was not there. We learned by assisting teachers, and we were spend most of our time in the wards. This was what the old type of, that is the type which of post graduation which we did that at that time, mostly spending in labor rooms, wards. So the clinical experience what we gained, that was what as a knowledge we spent. So that is what my experience, 30, 40, not only my experience, at that time, whoever has done post-graduation 30 or 40 years before had did the same. I think you also have the
Yeah,
same
also I
experience.
was a first year resident in BHU also. So first year was really hectic. We hardly used to get time to go to the hostel. Most of the time we are learning. Actually, that time spent in the ward is what all we learn. Whatever experience we have, we still remember those days, writing history of the case sheet, sending investigation, running with the trolley, taking the patient to the OT. So that experience lives for lifelong, and that is a learning experience actually. So sir, what do you think that there was strength of the older system? Do you think
See,
those system are losing nowadays or changing
and then
nowadays?
the strength of the older system was that, the number of, you should understand one thing. The number of postgraduates were less at that time.
Yes,
Uh, and the clinical number of deliveries were more, or the clinical material was more. So we used to get lot of hands-on experience.
yes,
So the strength was the oldest, is the unmatched clinical volume. We had unmatched clinical volume, and we had large diversity of cases. So the advantages was, and another advantage was that, see, whilst we were spending most of the time in the hospital itself, we had very close relationship with our teachers. So
yeah,
that mentor-mentee relationship was very close. Actually, evening after spending all this at 10 o'clock with the duty person, we used to go out and have coffee and tea, and we used to have dinner. But the whole day we would not have taken anything. But that relation which I maintain now also, that strength. So I feel the strength is that the large volume of cases which I handle, the clinical exposure, as well as the relationship which we maintain till now, madam. I do a special case. I called at that time, my HOU was Dr. Nilesh Shah, or Aresh. Do I say that, sir, I have done a new case. New thing may
mm,
not be something which it is nothing matter to, but it feels me so happy. That
yeah.
relationship is not there with the postgraduates now. The two things I feel was that one is the large volume of clinical, that the experience which I got, as well as the relationship with the teachers, the both
Yeah, the
things.
teacher student relationship was too respectable at that time, and also the relation with your seniors was also very like you said, after a hectic long day work, maybe without breakfast, without lunch, we used to hang out at the dinner time with the seniors. So that connect
Madam,
was
that till now your seniors in the postgraduates also, you keep so much. You feel so happy to seeing them
uh,
in a conference or meeting them
yes.
and discussing with them. We feel that relationship was more strong during our older days than the present day. Present day is like everything superficial. They come there, they work their duty period over, they
Yeah,
will
that
leave
I
the.
too agree that the personal connect is less and less nowadays. We still feel so great about our teachers. Like my guru is Dr. Manjukita Mishra, madam
Ah,
from Patna
madam,
Medical College. She was my guide. So for every maybe I'm not talking to her every now and then, but for everything I do feel gratitude for her for everything of
that is what.
mine. So, so nowadays, this curriculum, the new competency-based curriculum has come. So, how do you think this curriculum has evolved from traditional to this current structured training system, what we call as competency-based
The,
system?
the curriculum. See, this curriculum, the new curriculum has already been implemented in the undergraduate level,
Yes,
and I was there giving suggestions for the curriculum from Fogsi. I made the whole curriculum with the discussion with all the teachers all over the during the presidency of Dr. Alpesh Gandhi. So we made it and we submitted it to NMC. So NMC is coming out with it. So the new curriculum, whatever, it's a patchily here and there in different medical colleges, this has been started implementing. The advantage is that it moved from what is from an unstructured, we are going from the structured curriculum. So here, what is it? We have certain learning objectives, we have timelines, and we have assessment. Three things which you should understand is that.
yes, yes,
So learning objectives, we have a timeline, and we have an assessment, and we have simulation labs, we have modular teaching and a structured rotation, ensure that there is a balanced exposure to cross specialties. So that is what the new curriculum is. So as the discussion goes on, I will explain to you more about the new curriculum.
And as you were talking about it, the new curriculum includes the simulation lab and trainers, laparoscopic trainers, online module. But that curriculum has, but now the PGs are more inclined towards hanging on to online learning. Like they feel it very easy. They will Google, they will go to the YouTube, they will all have all sort of online courses which are going on rather than paying attention to their teachers. That is what I feel has.
So that is because of the curriculum, madam. See, there is no structured assessment of your skills. See, there is no examination or anything you assessing the skills actually. So what I feel is that you should also feel the same thing. What I feel that instead of only, if you see, only there is a theory exam and an oral exam at the end. Okay. So most of the present scenario students want somehow to pass the exam. They are not thinking about their future. Okay, they want to pass the exam. So that is the reason why they don't spend much time in the walls. They spend more time in the Google, more time in online classes, more time, and they want to somehow pass the exam. They are not thinking of the future. What I felt is that there should be a structured assessment, skill assessment, simple example I will take. See, at the end of first year, okay, first year a PG training, they should, in the hospital itself, we should assess them how they take a delivery. Like they anyway every day are taking, but there will be an assessment where the teacher will be standing and marking them how they future episode.
Through the that checklist, what we call
and
is
through the
objectively
checklist, and
structured
now
clinical
the checklist
examination.
what they have only combinations you are able to do or not, you are trained, or these checklists are coming. That is what the new CDME criteria check. But checklists are more of documentation type of thing.
Yeah.
So they are sitting and feeling all
So
these things.
sometimes they just mug it up and just try to do the thing accordingly.
That is what you correctly told actually. So the importance of skill development has coming down actually. And one thing is that for students that the number of patients is in the delivery rate in the whole country is coming down. Especially in Kerala and all, delivery rates have dropped to half actually. So, and the number of PG seats are increased. Okay. So, the exposure what they get is very less. That is the problem that I see.
Yeah, in some, especially in private medical colleges, I think the actual hands-on training on patient, the opportunity is very less. So that is why we have to take resort to the simulation lab and all the trainers.
One suggestion from which I can give is that, see, anyway, government, they are all coming under, they are all written entrance and taking. So when you are giving a seat to a private medical college, see, you cannot insist that they should have all the deliveries there. See, if they don't have that much clinical material there, they should have a rotation. I have a simple example I will tell you. When I was doing my postgraduate, my colleague, my roommate was Raj. He was a radio diagnosis student from Tamil Nadu. Another student from Jamnagar used to come to our college, BJ Medical College, because MRI was not there in Jamnagar. Okay. So they used to get trained for 3 months MRI the year. And like that, in gynec also, if your private medical college does not have that much, government only gave us a seat for the private medical college, they should ensure that it is not the other medical college. There are so many district hospitals, so many private hospitals who have a lot of deliveries. Government should ensure that these students should get adequate exposure by giving them rotation in these surrounding hospitals. So if the government takes a policy, it is possible. Government tells that you should give training.
This has come up with the district residency program.
That is what I'm coming to. It's called the DRP program. During the DRP program, this 3 months training, it's an excellent. So they go to a rural hospital or the district hospital nearby. So they get a lot of exposure of the, not only of, see, even if from an Apex institute like AIMS or your institute, you have everything, all modern things are there, but the students are not getting that rural exposure. So that students goes to a rural area, works in the future that all these things are necessary. So they get hands-on experience on sterilization, hands-on experience on NGP, hands-on experience on so many small, even if it's a small procedures which are a must, and lot of deliveries will be going on. So there they will be allowed to take they have to take night duties where they will be doing alone with the supervision of a consultant. So they will be doing so. Their confidence level increases here, along with 20 PG sitting on or standing on other sides with 4 consultants on duty. They don't learn to do it that is what.
But don't you think that at some places it is being misutilized by the residents? Because in government college where they do have caseload, so they take it as a kind of paid holidays for 3 months.
That
Actually,
is what. Uh,
that
so so
sometimes, so it is
so
kind of double-edged sword, I think. At places
your
it works.
suggestion should be like this, madam. See, the places you have to restructure it.
Yeah.
Places where there is adequate work, they don't need rotation.
Yeah,
So here,
that is very good point.
ah,
Actually, the government should think about it. What
ah,
are the places, what are the medical colleges where PGs really need a district residency program?
that is what government. In short, their PGs. I have given a suggestion to NMC that in short, the government medical college PGs don't need rotation.
Yes,
They
that is
go
what
for
I also
rotation.
think,
They
sir.
don't
I
work
strongly
sincere.
think so. I
And
also.
they feel that I know all these things, so why should I? What is this there in this? And this
Uh,
management is not correct. That man only they have complaints. But a private medical also they will so happily go
yeah,
around and work very sincerely. That
they
is
get
what
hands-on actually.
hands
So
on.
this suggestion, I think, should go to the NMC and to the government. Do some restructuring of this DRP, whether it is really
Two
required in all
things I
medical
want
colleges.
to send to them. One is this restructuring. Other is that every student that competency, not only the competency on paper, competency that the student should, that's a generalized thing. See, all over India, they should have a structured thing that is a protocol based structured thing that a PG student when passes, minimum number of deliveries that should be taken alone, minimum number of surgeries that should be, minimum number of hands-on that should be made sure actually.
Yes.
That is what I
So
think.
there is some uniformity in
In the
postgraduate training. And sir, with this introduction of subspecialties like fetal medicine, reproductive medicine, gynec oncology, uh, how the training landscape is changing?
see the now one good thing I will tell you. Students get exposure to all these things. See, for me, I will tell you, I studied in BJ Medical College. There was a cancer center nearby. So I was posted there. I got, and I did 1 year fellow. I know what gynec oncology was. So I did 1 year oncology fellowship. That changed my vision actually. So I became very confident about the anatomy. That is what the future, whatever I become a surgeon, I could be a better surgeon only because of that training. So, so the good point is that when they have structured rotation, they get exposure to all the specialities because nowadays it's a subspecialty era. Though those who pass out, not like us, madam, we do everything. Not like us. Now a student who passes out has to do some specialty because in the future, as you asked, there will be only some specialties. High risk pregnancy will be managed by a team, high risk pregnancy team. Infertility will be managed by endoscopy will be managed by different team. Oncology will be managed by different team. During a postgraduate training, the small problem what happens is that when we were postgraduates, we were all type of cases were in our ward and in our own. So we got exposure to all type of cases. Madam, you understood?
Yes.
Now you have a, so for example, one of my PG, I will tell you. We have now structured. You have to go for 3 months in infertility, 3 months in oncology. Like the second year, there is a strict rotation. The problem is she was sick during the infertility training. She never got infertility training. One person goes on maternity leave for 6 months. Many times when she comes back, she's posted in the, even if she does extra, she's posted in the parent unit. She never. So the exposure many times, if it is not strictly monitored, the exposure to the subspecialty they misses, and they misses on so many. But our advantage was that ovarian cancer was operated in our infertility patients were seen,
Yeah.
everything was seen. So
Everything was
everything
done.
was managed.
Hmm.
That is what the difference is. So they have plus points also is there that they have broadened their vision. They got exposure to, and they know now what each specialty is meant for. And all these things are good points about. And the bad and the negative point is that sometimes they misses the whole specialty itself,
Yes.
and they don't get exposure to a good thing. That is what.
Yeah, so the structured rotation is good only because in many medical colleges there are specialized units also. Some unit is doing good in oncology, some is doing fertility. So when the PGs, I also want to know your opinion about this rotation of the PGs within different units of this of
That is
Oxford
what.
Gynae.
See, one small mistake in many colleges does is that you get a postgraduate seat and you go to that. The whole 3 years you are posted in a single unit. I was posted in a single unit under Dr. Nilesh for the whole. But at that time, even if I was posted, I was very enthusiastic. So I used to stay there. When Harish Doshi sir comes for night for a case, rupture uterus, I go and see this case with my effort. Okay, with my effort.
That is your student
If you
effort.
are not self motivated, you will be in that unit. And if that unit does not do any laparoscopy, imagine you don't get any exposure to any laparoscopy, and you are not motivated to go take some extra effort to go to other units. So sometimes other unit PGs may not like when we go there. So I am telling that every unit they should be equally rotated. So first year and third year they should be equally rotated. Actually, I feel that there should be one more year along with that, where fourth year, that means fourth year, which specialty they like, they should go and work in that specialty and get specialized. Come out as a, then they can go for any specialized training, MCH, whatever they want. So at least they get an exposure of what they like actually, or what they miss. If you want to, they are interested in endoscopy. There should be endoscopy unit that they by
You mean
rank
the PG
preference
should be of
merit.
4 years? 4 years training. Yes, sir. Actually, I also think the rotation in the different units is it should be mandatory. I think at least in second year, and when they have to come for the thesis, they should come back to the guide. That is how
And
we plan
one thing
rotation.
very important, you mentioned the thesis. Okay, it is
Thesis also I
the
want to discuss.
thesis. The one thing which is given least importance is research and thesis. Okay,
Yes. So that
you
was one
see,
of my question. Let me put it in front
uh,
of you. Thesis and research component, do you think are given due importance nowadays, or it is
uh,
just a formality?
that is the worst. That is the thing which has given the least importance. What is thesis? So for my postgraduate, what is thesis is that we ask them to select a topic. Most of the teachers are not also well versed in research, or they are not in the very busy gynecologists. So the problem what happened, they will bring topics. Actually, when they bring topics, we don't have any method to test that this to find out that this was done in Ranchi by another student. What they do, they will take a topic 10 years before a student in Ranchi would have done, and their friends would send that thesis as a PDF to them. Here only patient data is fed and rest of the things are the same. So something like a re-research they do, they want to
Yeah,
pass out and go.
novelty is not there. And actually,
Ah,
the in our college, we have started this 3 days thesis writing orientation program for first year students. So that gives some idea about
yes. And
selecting the
Foxy conducts
topic.
this
And
mix-up workshop, which is very good.
yeah,
Foxy
Pixel
conducts
Workshop by Foxy is very good. Yeah.
very good. So we always, every year, we conduct one in Thrissur or where my place, where whatever we do, they will listen to all these things.
Yes,
They will
but they
believe
will
it.
do their
But
own thing.
the only thing what that NMC should, another suggestion to NMC is that they should be along with the exam. Thesis is their discussion 10 minutes or there should be in PhD, 1 day is for exam, other day is for discussion of thesis and your research things. So the research is the future, madam. If you
Yes.
go to UK, US and all, nowadays students writing PLAB don't get any posting in UK, or because they ask for the research or publications. So once you don't have that attitude of research, see, imagine when my postgraduate days, I am always interested in research, the most interested. So unless you do only, so I had to do at that time. You don't have internet and so books you have to go to the library and search for the books. So in BJ Medical College, so I wanted to publish something. I went to another medical college nearby, VS Medical College, and get permission. Went to their library, took the book, so much effort was taken, and I published
Yeah, that's
an
true.
article in an international journal during my postgraduate. That was so much effort. Now it is very easy, madam. All
Yeah,
are
for
in the
writing
internet.
thesis, sir, I remember I had gone to Delhi National Medical Library to collect the literature
Ah,
because at that time we didn't have this opportunity of online thing, the internet. Now it is so easy for PG students. Actually, if they're motivated, they can do so much. Literature search
okay.
is so easy for them.
So
And
I
now with this,
motivate, madam, I motivate them, as you told, I motivate them so much to do research actually. This is one field that we have to insist, madam. We have to, this is, so I motivate them so much, ask them to make original articles, present, publish, and always in UK they say, either you publish or perish.
perish.
You
Yeah,
don't,
perish.
so the publishing and this nowadays, NMC has made many strict rules that if you don't publish, you will not get promotion. And these are all namesake. There are so many sites where you get and publish by giving money. You can publish anything, whichever useless work also you
So
publish
that
and get a
those are
paper.
predatory journals. You can
Ah,
publish within 24 hours or 48
24
hours.
hours and get
But of
that
course,
show that, and okay, you are a author and you get promotion. So whatever we'll do, but for a student there should be a separate day or the thesis or research discussion, then they will do it, and the marks will be equal to the viva marks. There should be 200 marks, 200 marks on thesis and research discussion. Then everybody will do proper research, and we should be motivated to on that day sit and ask discussion on stat. Then on that day they should know basics of statistics also. They write exams and pass all these things because it's mandatory, but they are not applying to these are all the future. So another thing we should insist to NMC is that research should give an equal importance, and research and thesis. So research for postgraduate mainly is thesis. So thesis, when you have to have a proper work, and it should get published before they go for the exam.
this publication part is really difficult for them to get because they will just pass exam and forget about their thesis. And we take so much effort in giving them the topic, following their thesis, right, getting it written in a proper way. And sir, what do you think about the role of AI nowadays in writing
Ah,
thesis? That
see,
is that
uh,
spoiling the things a
so
lot, I think.
AI is very supportive. I always tell AI, I'm not against AI.
Yeah, we
AI
are
should
not
be a
against
support.
AI.
Simple examples I will tell. See, last week I will tell you. We wanted to a patient with a referred with the endometrial malignancy was there. She was bleeding. Okay. So I have to do. She was continuously bleeding. So no way I have to do MRI and surgery next day because to stop whatever I give, it's not stopping bleeding. So plan for they were also concerned. Do it, do it, do it. So night I did the MRI. Okay. Night nobody is there to report. I got the report in 5 minutes. It was reported by AI. Reported by AI. Okay, so I got a rough idea. So in our hospital, the AI reports actually, but the final report is given by the radiologist.
Consultant. Yeah.
So it is just the same thing can be done with our CTG. So in the future, AI cannot move away from AI. AI will be there. So, and I think both should be complementary to each other. And AI can never don't now the new postgraduates think that AI is going to replace all of us, and we don't never can replace anybody. AI is always supportive, and it will be supportive, and we have to be proactive. We have to be accepting it, and we should also use the AI benefits of AI.
Yeah,
But you
the
cannot
AI
believe
should be
completely on
taken
it.
as a help.
Help.
For
That is
something,
what.
it is very good, like drafting, giving a summary. But nowadays there are apps of AI which can write the whole. You just give them the topic, they will just finish the paper within one day. But of course, there are apps which can detect actually plagiarism based on AI. So that is very good
There
thing.
are
Otherwise,
see there are even students if you give some work to students, they directly bring AI. So there are apps which you put it, and
ah,
one small thing you can do is that you do some updation on it. Okay, whole there it will get changed actually suddenly. So if that changes, that updation changes that AI, that whole material, then it means that it is completely downloaded from AI. So nowadays, no use of giving work and if you are particularly giving some homework, write and come and all these things, they will directly copy it from AI and be there. So that is the AI
Nowadays,
protocol.
even school children are doing homework through AI.
Homework to AI. My son sitting here doing all the homework through AI. Not only his homework, his friends' homework also he does through AI and sends them. That is what.
Mm. So you were talking about UK. So what do you think the PG training in India compares
See,
with the developed country?
developed countries like UK, US, and all. So, example, they have a very structured training actually. The advantages I will tell you first. Advantages
And
I
I
will tell
think they
you.
have very
Very
structured
structured training,
assessment also, sir.
protocol based, very
Yeah.
structured training, protocol based, and they practice evidence based medicine. Okay, evidence, it's called evidence based medicine. They practice. So they are when you go through the protocol based training. One thing is that you have a standardized training. That means that is done every doctor in that country does the same thing. So we know where we went wrong, what was the next step, and all these things are there. But in the UK, the clinical exposure is very less.
Yes.
Our clinical material, what they get, so the clinical acumen, that is so they do when the patient comes with pain, all these things are done. Tick, 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 tick.
Yeah.
Checklist is there. And one other advantage of UK training is that students get lot of free time. That is the family life and the comedy. All these things are necessary for the mental development actually. So these are all plus points of UK. But the minus points which we feel is that they don't have that clinical exposure
The
that we have
variety
actually.
of clinical cases, development of the clinical acumen. And but nowadays, I don't you think, sir, the PGs are very much like ultrasound dependent. They don't want to do pelvic examination or clinical examination. But we rely on our two fingers for the diagnosis. Our fingers are enough for diagnosis.
See that generally in the whole system. See, madam, we remember that everything we had only one ultrasound machine. Okay, and you remember you in our days that radiology PG is the most sought after person. So when we 8 o'clock at evening and all, we go and say that please we have 4 scans waiting. As medicine people will say four. Then he will say I will go and have dinner and come back. And then so we will wait. We will not have had lunch, breakfast, and dinner, and then also we will be waiting in front of his room before he goes and comes back after 1 hour. So that was what was there at that time. So all we have to depend is on clinical sense. We don't have time to do. So our with our clinical sense we differentiate abruption and we say that okay, the abruption we take it for. Nowadays, due to over investigations, the clinical judgment has come down.
Yes.
Many times that creates problem. All these machines cannot many times cannot give you the correct information. Many times take an example of an abruption. You cannot detect a small clot or separation, and they can say that there is no retroblastal clot. After half an hour IUD baby you will get, and the patient will be
And the
in shock.
patient shock.
So,
Yeah. So that will
so this
absolutely
is the
be.
problem of.
I always stress on this clinical diagnosis first. Whenever I'm in OPD, whenever my resident will start with ultrasound finding, I just ask them first, tell me the history, do the examination, give me the clinical diagnosis, then you go for the ultrasound.
The
So
same
it
thing
is.
PG should anyway. It's a discussion. PG see even before surgery on table. Even the patient is on table before doing every investigation. Even MRI will be there. But after giving GA, I do vaginal examination
Yes,
and see that
absolutely.
the uterus is above. That gives me the maximum information than
Yes.
anything, madam.
So
Uh,
examination under anesthesia. I always
ah,
tell my resident, learn this thing. This clinical acumen and doing examination under anesthesia will help build up your clinical acumen a lot. So
That is
I
what.
think
So all these things are so the basic. Everybody should understand that all the postgraduates should understand the post training should understand that see the basic clinical examination stays there. Whatever comes, whether only supplementary. And teachers, one point, madam, the teacher should be also trained.
yes,
See, not only the students. The updation should come to the training programs. The faculty training programs is a must. Another point.
That is going on with this NMC, no, sir. Faculty Development Program is that BCME, Basic Course in Medical Education. Every teacher has to do this. Because without that, we are not getting promotion.
That is correct. That is for how to teach. I am telling in gynecology, all the basic skills like drills, all these things, whatever updated, our association Fogsi itself comes with so many emergency obstetric care, so many things, mock courses.
Mock training.
Every president has their own, and that utilize all these things. Make sure that, and the government should also make sure that the new things comes. Every faculty should undergo this program, and it should be implemented in there. So unless you teach the faculty to latest things and train them regularly, and one thing which we don't have training, faculty assessment should be also there. Like US and all, you have to be assessed yourself. So every faculty, at least in a medical college, has to get assessment. They should be having actually skill based. Okay, don't put them a theory exam. They can have an MCQ exam with a skill based training. There you can show them these are the. So you have to pass every time. You have to upgrade your knowledge every 3 yearly. Leave it every yearly. At least every 3 yearly they have to be upgraded. That will give advantage for teaching for the students. That is what I feel.
And if we were talking about the work-life balance in UK is great for PGs. What do you think about their work-life balance in India?
India
In our
changed,
country?
not like our. I still remember for my marriage actually. I did not go for my engagement to see my would be at that time. My wife. I only went on the previous day of the marriage actually. So that was what the leaves given. Our life was so. It was fully dedicated to work,
Yeah,
work.
dedicated to work with no leave.
Now we have
Yeah,
changed actually. Now we
yeah,
have changed. A weekly off is a must according to NMC. So all the
yes.
request all the teachers who are listening, give them that weekly off and
Yeah,
see to
weekly
them
off
that
is there, yes.
uh,
And 30
we
days leave.
30 days leave is there. All these things are on paper there. Many places they are not really, you may not be knowing, many places that are not practiced properly. So it should be
Yeah,
practiced. The
yeah,
mental development is very important of the postgraduate also. The children are also like children,
yes.
not like
In
strong as
Bihar
what
and
we were.
Jharkhand, sir, things are a little easier. So
So
when,
the problem of this is that problem is there. Problem is that this is that they don't take that we used to be there in the whole time in the ward. We got extra things to see. They don't get that extra because they take or leave duty is there. We give them duty off. But even if we officially give them duty off, if they are interested, they can stay. We don't say don't
yeah,
no to them.
it is up to their motivation. If they really want to learn, they can ask their friend, the interesting case is going on. You can always come from the hostel and see the case. So we used to do that. Whenever
That is
interesting
what
case was going on in another unit, we used to go to that
I
OT.
will tell you. I will tell you 2 days back, actually. 2 days back, nothing. I was a placenta percreta referred came with bleeding at night 2 o'clock. Okay. Imagine such a case comes. I'm operating it at 3 o'clock at night. So I called the postgraduate who was there on duty. I told them to tell the other postgraduates. Hardly 2 people came. Why? Because he put it in the WhatsApp group. I told them to call others. What they see, put in the WhatsApp. Who will see that WhatsApp message at 2 o'clock at night? And only because there was so much difficulty that case. We did a 5 laparotomy before, and to see that case was the person 3 hours it took to do that case completely. So many things were done in that case. So people who know, so nowadays that motivation, I feel, you also feel, madam,
Yes,
motivation from
I
the
do feel,
students are
yes,
less actually.
yes. Motivation is less. They will say, okay, we will see.
So we
Maybe in
cannot
the
scold them
YouTube.
also because if they were not on duty on that day. See, if they are on not duty, we can tell them that you are. But that self motivation does not come nowadays. That is what we feel.
That's true. So, sir, what advice would you give to the current PGs to make most of the 3 years of their training, regardless of limitations they have?
See, the best advice is that make them be the proactive. That means don't wait for cases
Yes,
to come to you. You volunteer, you observe, you assist. See, I will tell you. See, everybody wants to operate. Like the same thing. See, when I'm doing laparoscopy, nobody wants to sit at the vaginal end. Vaginal end. And they will skip somehow, they will make the sister sit there and they will skip and go to their written work. Or see, the most maximum what I learned, laparoscopy, I was trained under Hanjay Patel, sir. Not training actually. What was the training, At that time, no proper training was not there. So what I used to do, my free time, after that 3 years, I was doing that fellowship in oncology. Evening, I was free. So evening, I will go with him in an Omni car to different places. The main thing I was doing, I was carrying the TV, gas. So we set up the OT there. I sit at the vaginal end. The maximum, madam, I tell you, maximum I learned during that 1 year. So, but the PGs
Yeah,
don't
because
understand.
observing keenly is also part of learning.
That is what they should understand. Observing, assisting. Assisting
Assisting.
is the very important thing that don't doing. So
For
they will
first 6 months, you have to observe, another six
uh,
months you have to assist, then you
and
start.
one more
That is
thing,
the proper way of learning.
all this measures that whatever see like simulators, endo trainers, and all these things they have to utilize. Every private medical college will not have that much bulk of case to make them do. Some private medical college, top end medical private institutes are there where they seats like VIP is there. So all are VIP patients. So the consultant, even if they want, they may not be able to make them do that case.
True.
Do make them do this. So what they have to do is that they should get time. They should spend more time on simulators. That is what they should do. That is what.
Yes. So, sir, if you have power to redesign the PG curriculum, what are the three things you would like to do?
See, three things which I will tell you. One is balanced training exposure, what I told you. One word is a balanced training exposure. Make sure that every postgraduate, either in the government college or medical college, gets at least a minimum exposure. That is the first thing I will
Yes,
do.
minimum.
Then I will integrate soft skills. That means what is the soft skills? What you know is that communication, ethics, and teamwork. This is what is missing now.
Ethics is very, very
So,
important.
so that is what NMC should. This should come in the curriculum. One of the most, if you are a surgeon or you are wonderful, nothing matters unless you don't cannot communicate
Professional ethics.
properly.
Yes.
Every problem that gynecologists face is due to lack of communication. So you are not able to. There is a mishap. Same medically can have. We are not God to save all the patients. A mishap occurs. We know that it's not our fault. 99% of time it is not our fault. But if you have not communicated properly, if you have not documented properly, if your teamwork is not good, understood, you have to, so you should have created very good relations with not only your colleagues, your sisters, your ground staff, your all staff, other department like surgeons, urologists, neonatologists, very important, anesthetists, all this teamwork. So building up a team, that is what I wanted them to. Then balance training and mentorship. You should have a structured mentorship. Every postgraduate coming should have a mentor. So these are the three things which I feel, which I will insist them to have for their future better
Every
postgraduate training.
PG, they have a guide allotted to them. So
But
mostly
that
the
gate
guide
they
is mentor.
utilize only for thesis. That is the thesis gate. So that gate should be a mentor for everything, surgical
Yeah,
work.
for
Uh,
everything, not only for thesis.
that
Actually,
is what.
mentorship, the guide should act as a mentor also.
Maybe you are, madam, at your level, because you are in a hospital where it's a premium institute type of picture you have. Such an institute, when you have, there will be mentor and all this structure. So that type of teaching, I want it to be done in all the, see, for example, you are studying in All India Institute of Medical Science. They will say that, insist that you should, the first year, you should do this many DNCs, this many, at least you should have done 3 cesareans, you should have taken 10 deliveries, you should have like that. That structure, finally, when you come, at least you should have done 5 hysterectomies. That structured training should be there.
Yes, sir. Thank you so much for your input, sir. And I think we should come to the last part of my podcast where I do rapid fire
You are as
section.
a quiz committee chairperson, I
Yeah,
expected
so
that
rapid fire has to
rapid
be
fire.
there. Yes. So in my podcast especially has this rapid fire round, just one liner or one word answer from you. One skill every OBGYN must master before finishing PG.
One skill, what I say is that they should know how to take a normal delivery and manage PPH. That is one skill that is because it's PPH is the maximum death occurs. So if you don't know that, that is a skill you should develop.
One outdated practice we should bring back.
For instrumental delivery. Instrumental delivery. That is nowadays most of the postgraduates coming from different. But instrumental delivery, if you properly know, your cesarean rates will come down and your all
Yes,
the
assisted
complications
vaginal
will come
birth. Yes, of course. One hyped change in recent years.
down. That is documentation. The excessive documentation has been by all because we all want to NIBH accreditation, quality standard accreditation, all this accreditation. Finally, what happened? The load is on the postgraduates for filling up. In the morning, you will come, they will be filling up all the. See, you have to do documentation. Documentation should be there. Along with documentation, they should develop the skill development is not. That is what. So, one thing should be decreased is documentation.
Evidence-based medicine or experience-based medicine?
That is it should be balanced actually both it should be there, it should be balanced, evidence based, and you should practice evidence based medicine along with patients.
Experience.
So like that, it should not
Simulation
be
lab or real patients?
it is the skill lab should be initially skill lab. So everybody who joins have to go through skill lab. So they should be strictly told 3 hours of training and all this. Then later, because it decrease the risk on the patient. So it's a risk-free environment. They can do anything on a simulation lab. Now see mummies have come. They are obstetric.
Yeah.
You would have seen that mannequin where it will cry, it will, you can breech delivery, you can put like that. So simulation is there, but future you should get. So both is necessary in a postgraduate phase.
Most difficult case you handled as a PG?
That is what I will tell you. As a postgraduate, I still remember that case of a amniotic-fluid embolism. See, it changed my scenario. Life. See, patient. I was a second year postgraduate at that time. Patient was 4 centimeters dilated. I did an ARM. Nothing. Patient was a second gravida. It will deliver within. Usually, what happened? Deliver 3 to 4 hours. It will deliver. Good contraction was there. Did an ARM. Suddenly, patient started gasping. I did not know what to do. Suddenly, when the saturation fall was there, so immediately anesthetic was called. Patient was not able to take breath. They intubated the patient. Fetal heart was coming down. Immediately, patient was taken. I took because there was nobody. I took the patient for cesarean. So with the senior, because the consultant was arriving only. That is in duty. Immediately we took the. But even then we couldn't asphyxiated baby. We couldn't save the baby. But what happened, madam, after putting the incision, we could not close because patient was continuously bleeding because at that by the time patient has gone in for DIC. So first time I am seeing. Then I understood that the last 1 year, whichever amniotic fluid embolism in that hospital, every patient has died actually. And we all lost hope. We somehow closed the abdomen, put drains. I still remember one thing. I myself and my junior, because it was something like a punishment for me. Junior was getting blood and I was pushing the blood like this. There was full chaos for the bystanders, politicians outside, and my consultant and the senior was difficulty managing these people. Everybody lost hope. I sat there and was pushing the blood inside. Whatever was going, the blood was dripping from down from the bed itself. And after 2 days, actually, 2 days, patient, that was the first case of amniotic fluid embolism, patient survived. So it
Yeah.
was a big
So much
party in
gratifying it
our.
will be.
That changed my scenario. That I till then I have heard that amniotic fluid embolism nobody will. That gave me confidence and that changed my life. Even I gave one blood to that patient. So I have always felt that okay, I gave my blood only survived that patient. So that was one of the most interesting changed my
Yeah. You
life
do
in the
remember one particular case during your PG training. Everyone will have that.
post.
One last question, one word to describe the future of PG training.
It should be a hybrid, actually. Blending, it should be a blending technology and hands-on experience. So it should be hybrid means it should AI and hands-on experience together should be blended together.
Yeah, taking optimal advantage of both of them. So thank you so much, sir. I hope
I enjoyed.
I thoroughly enjoyed talking with you because it was really two postgraduate teachers talking to each other, and I hope the viewers equally enjoyed it. And so thank you so much, viewers, and stay tuned till the next podcast. Thank you
Thank
so
you.
much.
Thank you so much.
Bye.
Thank you.